Hey NCS podcast listeners, this is your host Fawaz Al-Mufti from Westchester Medical Center, New York Medical College. Desperate times call for desperate measures. This is especially true for many of us in healthcare, as we find ourselves adapting to new roles and new units, innovating to tackle a new disease while adjusting to a new surreal reality. Hence, in an effort to reestablish some degree of normalcy, we decided to resume the release of our episodes on the NCS podcast. As they say, the show must go on, and at least now you can listen to something that is non-COVID related for the next 20 minutes. Over the last 20 years, the inclusion of advanced practice providers in critical care departments has allowed them to emerge as invaluable, ever-present team members, crucial to the continuity of care and a stabilizing force for intensive care units. As such, the integration, advancement, and education of advanced practice providers is essential to maintain a high-functioning Neuro-ICU. We're excited to collaborate with the NCS Advanced Practice Provider Leadership Section to launch the NCS Advanced Practice Provider podcast miniseries. Over the course of 5 episodes, we will discuss a variety of topics ranging from APP utilization and staffing models to billing practices, and hopefully present ways by which intensivists and forward-thinking advanced practice providers can work together to optimize the daily functioning of the neurocritical care units. I hope you enjoy this episode.
My name is Immaculate Fields. I am a nurse practitioner at OU Medical Center in Oklahoma City. I am the lead nurse practitioner for the Neuro-ICU Advanced Practice Providers. And today we'll be talking about article. It is titled Describing Advanced Practice Providers Within Critical Care Teams with Tele-ICU Examples from 7 U.S. Systems that was published in June 2019. We're lucky to be joined by Teresa Rincon, who is a telehealth director of Clinical Operations Innovations at the University of Massachusetts at Memorial Healthcare. She has served in several roles in telehealth as a nurse manager to director and has published several papers on telehealth. Today we'll be discussing the paper that I had aforementioned, and we're also lucky to be joined by Johnny Eisenberger, who is a clinical instructor at the University of Massachusetts with experience in telehealth and tele-ICU, and he will be speaking to us from an inpatient perspective. All right. We will go ahead and get started. And the first question I have for Teresa is briefly describe the historical emergence of telehealth and tele-ICU.
Tele-ICU began in the late 1990s with some work that was done at Johns Hopkins. And there were 2 intensivists who started to really think innovatively about how they could provide care for patients and be able to visualize these patients instead of sometimes answering questions and listening to nurses paint the picture of what was going on with a patient over the telephone. But telehealth in general has been around since the early 1900s. We began to see things like physicians using the telephone to order medications, and we saw the first EKG being transmitted over telephone lines, and that was in like 1904 and 1905, believe it or not. We saw other little experiments of telehealth occurring over the years, but we really started to see some innovative ways in which telehealth was being used in the 1960s. And that's when the aerospace industry and NASA began to look at what was happening with astronauts when they were in space. And they began transmitting vital signs, information, blood pressure, heart rate, and different other physiologic data from space, and then were able to monitor what was happening. The second thing we began to see is in the 1970s, we saw an innovative group of behavioral health specialists who used NASA telecommunications equipment to treat patients in our Native American reservations. So really this began to continue to grow. And then in the 1980s, when we saw the birth of the internet, we began to see even more utilization of telehealth type of technologies in order to enhance and sometimes provide care where care couldn't be provided before. In the early 2000s, I was excited and honored to be part of a group of nurses at Sutter Health in Sacramento, California. And we started the first tele-ICU on the West Coast and the second in the nation. And so those were exciting times. They were scary times because there was no blueprint. No one had articulated the practice of a nurse. doing critical care nursing over telecommunications platform. In 2004, Sutter Health opened their second Tele-ICU, and we began to see other Tele-ICUs popping up around the country, including where I'm at today at UMass Memorial Medical Center. They started their EICU there in 2006. And my colleague Johnny, who's with us, he actually works in both of the environments, the Tele-ICU environment, as well as in the critical care units at our medical center.
Great. What are the roles and responsibilities of advanced practice providers in the management of patients via telehealth and tele-ICU in different settings, academic versus private or inpatient versus outpatient?
In the academic center, I'm going to let Johnny talk a little bit about that. I'll talk about in the community health system since I have experience in both. So in the community health settings, they're used very similar. Their roles and responsibilities are similar, but it's many times dictated, as most of us know, by the laws within the state and the requirements in which nurse practitioners and PAs must practice under. So the article that you referenced earlier about the 7 exemplars, where we looked at across the United States 7 health systems using nurse practitioners and PAs and clinical nurse specialists, we saw similar but sometimes different utilization of those roles and how they were used based on licensure. And in those states, for example, in the state of Florida, nurse practitioners have more leeway within their practice, whereas the physician assistants needed to have more supervision. And Johnny, I know you know a little bit more about that on the national level and specifically in Massachusetts, and you might want to join in and talk about that.
Yeah, I'm, as Teresa had mentioned, I work in both the EICU and the inpatient setting, where I've been utilizing telehealth quite a bit, especially in light of the recent pandemic that we're all working in. When I work in the EICU, I'm able to utilize my skills and use telehealth to help manage patients across our entire system. And that includes a multitude of community health centers, other small community hospitals that are managing critically ill patients. And I'm able to give them some of my expertise alongside with an attending physician who is also working alongside with me in the EICU. On the inpatient side, I've been using a lot of the telehealth to manage these patients. And so in an effort to minimize exposure to patients or utilizing PPE and trying to conserve that, I've been able to use telehealth to help manage these patients alongside with the nursing staff. As an example, I had a patient the other night who was acutely desaturating. I was able to camera in via our telehealth program, eCare Manager, and I was able to help direct our prone team. I was able to help direct the bedside nurse on how to help manage this patient and improve their saturations. So it's been an invaluable tool for me to use at the bedside, especially during this time where we're trying to conserve PPE and we're taking care of some of the very sickest patients that we've seen.
And in the ambulatory setting, even in as early as the 1970s, we started to see nurse practitioners using telecommunication technologies to communicate with patients in very rural areas. And they've supported nurses and medics out in those areas. So there were EMS personnel sometimes out in those areas, but they might not have nurses even in those areas, and they didn't have physicians or advanced practice providers. So we've been seeing this go on for many years, but now it's becoming mainstream, especially with the COVID-19 crisis. We've been able to see it grow exponentially. In fact, it's been extremely difficult to keep up with the demand for both advanced practice providers using the technologies, physicians, and other ancillary staff who are seeing patients remotely. We have a huge effort in our behavioral health and psychiatry programs. We are able to provide many, many services over the two-way audio video systems. We have 2 different software vendors that we already had in place before the crisis hit, and we've been able to add thousands of users. I think we had less than 100 users on our ambulatory platform, and we're up to over 2,000 users on that platform today.
Well, those numbers are impressive. I mean, from less than 100 to the thousands. That is something that is really impressive. Now we're still talking about in relation to telehealth and the pandemic. The next question is, how has telehealth and tele-ICU assisted with the pandemic? And any words of wisdom, as many providers are using telehealth during the pandemic, what are your words of wisdom for this, for the providers at this time?
I'd like to talk a little bit about that. I think anytime you take on something that is going to fundamentally change the way that we provide care, and that's exactly what happens when we introduce something like telecommunications and telehealth technologies into how we care for patients. It's very different than the type of care we're used to providing. When we do this, it helps to plan first and to really go through all of the change management steps we would normally go through. And what we know in general project management is that resource capacity has to be planned ahead of time, and that having enough of appropriately skilled resources during a crisis is of utmost importance. We need to manage schedules and deadlines so that they're realistic. And we need resources to be assigned consistently. And when unplanned requests for resources and tools come in, they're considered scope creep in normal project management. Unfortunately, when we're dealing with a crisis, we don't have the luxury of planning ahead. And those become very profound weaknesses when we're trying to roll out something that, again, is going to change how we deliver care, and is going to do so using technologies that people aren't used to. So I think the best advice I can give people is to be patient. Would highly recommend that when there are consultant resources in telehealth, if you haven't done telehealth before, reach out to those that have expertise and let them help guide you in applying these new technologies to patient care.
What advice would you give to an organization facility looking into setting a telehealth and or tele-ICU program?
I think number one, you'd have to figure out what providers are going to utilize this at the bedside. And so, just as Teresa had mentioned, patience is key. And so you have to be willing to train and utilize this at every opportunity. It has taken a lot of creativity from UMass Medical Center to be able to use this and look for opportunities to use this in regard to our relationship with our community hospitals as well as on the inpatient settings. I think that we're also learning, we're also evolving and utilizing this use within our own institution. And this COVID-19 crisis has showed us multiple different ways that we could use telehealth to our advantage. Any advice I would give is, look for who the telehealth will impact the most, train those providers in those settings, not be afraid to utilize this at every possible way, develop relationships with a multitude of vendors and other providers in different community hospitals so they're willing to use us as well. I think the thing I've been able to see with this is my ability to use this in an efficient way and effective way in ways I didn't think were imaginable. I've been able to help patients in different ICUs from, if I'm working on an ICU, I'm able to help patients in another ICU with one of my colleagues who needs help. And so I think from an institutional standpoint, be creative, understand who your end users are, and train as many people as you can once this comes about.
Thank you. What are the benefits and limitations of telehealth and tele-ICU in relation to cost effectiveness, mortality, length of stay, and patient satisfaction?
Dr. Craig Lilly, who's the medical director of the Tele-ICU at UMass Memorial, and I and others published a paper in Chest several years back, I believe it was in 2017, on the financial implications of implementing and over time utilizing and sustaining a Tele-ICU. And we were able to do a cost-by-cost, patient-by-patient analysis and look at what did the cost of care change? How did it change? Did we see improvements in outcomes? And overall, what was the benefit of having the Tele-ICU in place over a decade on a financial accounting basis? And what we learned is that we not only saw an improvement in things like length of stay and mortality, which are important indicators of outcome, but we saw an increase in the volume of patients that we were able to take care of. We were able to keep more patients in their home hospitals and at the same time be able to still transfer patients in who needed the kind of care that only we could provide at the medical center. So these would be higher acuity patients. This allowed the hospitals where the patients would normally have stayed at to retain higher acuity patients and therefore increase their bottom line financially. And it allowed us to reserve our beds for the patients who needed our care the most and had acuity levels that were even higher, and that allowed us to increase the amount that we could reimburse and professionally bill for. So this was really important, and what we saw was about a $50 million to the good after accounting for what it cost to start the Tele-ICU and what it cost to sustain the Tele-ICU over a 10-year period. So we believe that not only did we see at this large academic center an improvement in outcomes, but we also saw an improvement in financial outcomes.
All right, great. Yeah, I think that not only is patient satisfaction, patient outcomes important, but also for a facility that's putting in that money to see the financial gain in the end after they put the investment in is great. The last question I have is, what advice do you have on telehealth and tele-ICU in terms of time management for APPs or even physician colleagues who are participating in telehealth and tele-ICU?
So we've seen an improvement in efficiency across our health system. We've also seen it I saw it across the health system at Sutter Health. And how this improves is that if you're able to get into the room of a patient quickly, see that patient, and provide that care, you're able to do that without having to travel between facilities. One way we do that at UMass Memorial is we have a pharmacist at night, and that critical care pharmacist helps to improve the efficiency and helps to manage the knowledge around critical care pharmaceuticals within our ICUs, and they do it from one location. If they were at a hospital and then had to travel to another hospital to do that, they would lose time in that travel time. Where we also see that in the outpatient setting is with our specialist physicians and care providers. So we have physicians who would drive to a clinic to see a patient. If they're able to provide that service over the telecommunications technologies, and we have several that were doing that before COVID-19 and many more that are doing that now, they're finding that they can see more patients because they read that time that they're traveling from clinic to clinic or hospital to hospital is time lost. You can't see a patient while you're driving or traveling. And when you use these telecommunications technologies, you can see even more patients. One way we saw that dramatically outside of the intensive care unit was with our teledermatology programs. So if a community health link or community clinic in Worcester, if a patient there needed to see a dermatologist, they would wait 6 months to a year. In our pilot study, we were able to demonstrate that patients were able to see dermatology at so much quicker. In fact, within 24 hours of a photograph being taken and it's sent to the dermatologist, a dermatologist will read that and then determine, do I need to see the patient immediately? And if so, they will get that patient to the scheduling department so that we can schedule that visit. Do I need to see that patient in a couple weeks? Can it wait? Then they would put those patients in the queue. And maybe I don't need to see this patient at all. It's a contact dermatitis or something else that they were able to diagnose over that photograph that we sent via Store and Forward. So this reduced wait times dramatically to see an extremely important resource. And we were in the process of rolling that out throughout the institution when COVID-19 crisis hit. So we're still doing it, but we have had to refocus our attention for the time being. But that's just one example of how you can take a resource that's limited and now expand the capacity of that resource to see patients quicker and make sure we provide better care.
Great, thank you. Do you have anything you'd like to share with us that I didn't get to ask in all the questions that I've asked so far?
I think some of the things we've been seeing across the country, and I know Johnny has spoken to this some, but the ability to use these telecommunications and telehealth technologies to expand the knowledge. So really from a knowledge management perspective and a knowledge translation of evidence-based practice perspective, we've been able to take nurses and nurse practitioners, as well as our intensivist physicians, we've been able to take their expertise and spread it across a large population of patients. One of the ways that Johnny explained that I'm also hearing from my colleagues across the country is these patients are at higher risk for needing proning. And proning is a complicated procedure and it's risky. And so having experts be able to call into the room via the two-way audio video and help to manage the checklists and ensure that we safely prone these patients is extremely important. And I've heard from my colleagues across the country that they are using these technologies to do things like that every day. We've also, as Johnny touched on, we've seen many hospitals within our own hospital systems, not just in critical care, but using the iPad technologies that we've deployed. We've been able to see a reduction in the use of PPE, which we know is a resource that's extremely limited, and we want to use it wisely. The second thing that we've seen that's been extremely important is we've been able to use these technologies to have those end-of-life discussions with families because we've limited, and in some cases, we've not allowed visitors in certain areas. And being able to have this two-way audio video so that patients and families can say goodbye. One of the stories that came out of one of our ICUs was related to a man who was made comfort measure only and was going to pass away soon. And they were able to bring in all of his adult children who were all across the United States into a video call so that they could say goodbye to their dad. So these kind of things are so important from a patient satisfaction standpoint and just from an emotional standpoint and being able to keep families and patients connected. I think that these technologies have really benefited our healthcare providers as well as our patients.
I really want to just echo what Teresa was saying and discuss how important telehealth has been to my practice, especially over the COVID-19 crisis. We've made such a concerted effort to conserve PPE and really use them for our bedside nurses as well as use them during an emergency situation. And so telehealth has allowed me to not only manage the patient and multiple patients in an efficient manner without really wasting the necessary N95s and gowns and goggles, etc. I also think, as Teresa had mentioned, the use of our iPads and FaceTime technology to really connect patients and their family members. As most institutions are enacting visitor restriction policies, this has become such an invaluable tool for our patients to be able to say goodbye or just simply have our patients hear their loved one's voice or just our loved ones be able to see their family members. That, to me, has been the hardest part of all this is the visitor restrictions and inability for loved ones to see one another. And so I find myself setting up times and schedules for family members to be able to call in, talk to their loved ones, even FaceTime with their loved ones so that they too can maybe rest easy at home while they're not able to see their loved ones. So to me, it's been an invaluable part of my practice, not only in taking care of patients, but connecting loved ones to one another. I also use telehealth quite frequently to connect with attending physicians overnight. I primarily work the night shift, and telehealth has allowed or has increased the availability of intensivists overnight. And so they're able to camera in. And if I have an emergency, I simply call my attending physician, and they're able to camera in from whatever location and really help me take care of these patients and give me some guidance on what steps to take and what things to do. So as an end user, as a user of this product, it's been such an invaluable tool for my practice.
Thank you both for your time and joining us on the call and sharing with us your expertise on this topic. Thank you.
Thank you.
Thank you.
The NCS podcast series is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, and advocacy in neurocritical care. Our production staff includes Fawaz Al-Mufti, Ramani Baloo, Mike Brogan, Josh Levine, Benjamin Miller, Sterain Shepard, Jim Siegler, Sarah Sternnezer, and Chris Zamet. Our senior producer is Bonnie Rousseau. Our administrative staff includes Bonnie Rousseau and Angel Gindel. Music is created by Mohan Kadapali from the Division of Neurocritical Care at the University of Miami. The NCS podcast series is available on NCS On Demand and wherever you may listen to your podcast. For more information, please follow us on Twitter @Neurocritical or on Facebook. I'm Fawaz Al-Mufti, and thanks for listening.